Hello and welcome everyone. My name is Jenny Opolinski. I am the coordinator of education for Aspire Products. And this is Head and Neck Cancer, an introduction to interventions for the SLP, hosted by Tactile Medical and Aspire Respiratory Products. Tactile Medical is a leader in developing and marketing at-home therapies for people suffering from underserved chronic conditions, including lymphedema, lipedema, and chronic venous insufficiency, by helping them live better and care for themselves at home. And Aspire Products is the maker of the EMST 150, the EMST 75 Lite, and the IA 150 inspiratory adapter. Aspire has been partnering with researchers since 2008 to create therapeutic devices that target cough, swallowing, and increased breathing capacity. Our goal is to improve the quality of lives responsibly with evidence-based science behind the products we bring to the market. We are very excited for our presentation today. I will ask you to please put your questions in the Q&A section that is not the chat. And I will hand over now to Brooke, who will introduce our speakers.
Thank you so much, Jenny. My name is Brooke Bielman. I will be introducing our speakers. Tonight, we have Katrina Jensen and Dr. Kate Hutcheson presenting for us. Dr. Kate Hutcheson is a professor and deputy director of clinical research in the Department of Head and Neck Surgery with dual appointment in the Division of Radiation Oncology at the University of Texas MD Anderson Cancer Center. She serves as the section chief and research director for the section of speech pathology and audiology. Dr. Hutcheson is a certified speech-language pathologist, a board-certified specialist in swallowing and swallowing disorders, and holds a doctorate degree in epidemiology. She maintains an active clinical practice and research program. She has authored over 120 journal articles with funding support from National Institutes of Health, Patient-Centered Outcomes Research Institute, the MD Anderson Institutional Research Grant Award Program, and the CPRIT UT Health Innovation Training Program. She is an accomplished clinician and educator who lectures nationally and internationally on radiation-associated dysphagia and head and neck cancer rehabilitation. Katrina Jensen has been practicing exclusively in the field of head and neck rehabilitation for 25 years, including her training with surgeons from the University of Pittsburgh. Following her 4-year training in Pittsburgh in 2000, she returned to her hometown of San Diego, where she developed a comprehensive head and neck program focused on laryngeal rehabilitation, as well as swallowing and voice disorders. In 2007, she joined Texas Healthcare to establish their head and neck rehabilitation program, which has since evolved to become the Advanced Head and Neck Rehabilitation Center of Texas. The center, as it is commonly known, now serves as the largest rehab center of its kind in Texas, caring for the rehabilitative needs of patients throughout the region as well as international patients. Throughout her career, Katrina has published and lectured extensively in the fields of laryngectomy rehabilitation, as well as medically based voice dysphagia and swallowing disorders. With that, I will turn it over to Dr. Kate Hutcheson to start us off.
Well, thank you very much. It's great to see a number of familiar names and on the participant list tonight. And I hope that we'll all be able to join each other live sometime in this upcoming year. Let me share my slides. I hope folks are seeing those okay. So I've been asked to cover for about 30 minutes the implementation of EMST in head and neck cancer, and specifically just review our experience and some of the data that we've accumulated with integrating EMST into a comprehensive dysphagia program in the head and neck cancer population. And for those who are more familiar with this population, this is really used quite predominantly in our practice in patients who have developed radiation-associated dysphagia as a consequence of their treatment. So thanks for having me tonight, and I'm really grateful for the invitation. These are my disclosures. I'm grateful for salary support from MD Anderson, of course, as well as research funding for our lab. So let me get this out of the way. So we know that airway protection is a major concern for patients with head and neck cancer, and this is particularly the case for patients who've been treated with radiotherapy as a component of their care or chemoradiotherapy. And here you see data showing the lifetime risk of a patient who's been treated with head and neck radiotherapy, specifically chemoradiation in this data set. The lifetime risk of an individual developing aspiration pneumonia after that treatment hovers around 25%. This represents a significantly increased risk over patients who have not been diagnosed with cancer, so non-cancer controls. And it's also associated with increased risk of death and cancer survivorship. When we think about the concept of airway protection, I like to conceptualize the goal for a patient of when trying to optimize airway protection as really being a balancing act. And that goal is often for an aspirating patient, particularly one of finding strategies that help the patient to keep eating, but avoid pneumonia. And this is a really ambitious or lofty goal, particularly in the setting of post-radiation effects, where we expect to some degree that normal tissue injury is going to be chronic, potentially progressive over the lifespan of the patient. So a lot of the physiologic impairment in swallowing is expected to persist despite the improvements that we might be able to achieve with compensation and with functional gains with our therapies. So when we're talking about airway protection in our therapeutic goal, one of the areas that particularly in dysphagia science that has come into a lot of focus in the last couple decades has been tapping into downstream targets in the respiratory system instead of focusing exclusively on what we might be doing in the upper aerodigestive tract. And examples of this include things like the respiratory pattern training data out of Bonnie Martin Harris's group now at Northwestern University. Here they're actually using biofeedback to help patients learn to recalibrate the time in the respiratory cycle at which they swallow. But the other really prime example of using a respiratory target for the goal of improving airway protection is the use of expiratory muscle strength training for this indication, and specifically really work led by Chris Sapienza and others out of the University of Florida. So we're familiar with expiratory muscle strength training, and it's been as a device-driven exercise paradigm. It's been studied. It's been clinically implemented to address airway protection for patients who have swallowing impairment, and also in populations who are at risk for developing it because of a particular disease process. And much of the early work using EMST for this indication was really in neurogenic populations with or at risk for dysphagia. So you can see here just some examples of both randomized trials as well as just prospective trials using EMST in neurogenic populations, Parkinson's, stroke, ALS. All of these trials had in common the observation that with somewhere between 4 to 8 weeks of EMST, patients were able to increase their expiratory force generating capacity. And that's really measured by the maximum expiratory pressure that's generated in a manometry device. And some of these studies also demonstrated improved penetration aspiration on modified barium swallow study, or improved cough, more downstream measures that are related to the swallowing function of the patient. So here we see a framework that was published by Michelle Trochet, Karen Wheeler-Hagelin, that introduced this concept of the continuum of behaviors that underlie airway protection. Swallowing, laryngeal closure, bolus propulsion to prevent airway entry on this left-hand side, and cough on the other end of the continuum. And I see a number of names on the participant list that suggest that there are a lot of folks that are familiar with head and neck cancer on the call. And I'd argue that for a lot of us, you know, in the head and neck cancer space, outside of glottic cancers where they may anatomically sort of alter vocal cord closure to generate force for cough and things like that, we tend to focus on this left-hand side of the continuum when we're thinking about how we can alter airway protection, and we stay pretty tightly on the swallow itself. But we understand pretty poorly the right-hand side and how cough is impacted in our head and neck cancer population. And that we're starting to see a little bit more data on this. Here's just one example. These are some data that we published at MD Anderson a few years back, demonstrating that the expiratory pressures of patients, so the MEP, as well as the peak cough force, are actually significantly lower in aspirating head and neck cancer patients relative to non-aspirating head and neck cancer patients. And this was testing about 100 of patients who came through our MBS clinic after radiation. And this might give us some concept that there's something to target with EMST if these aspirating patients, which are shown in black on this scatter plot here, have a lower MEP or a lower peak cough than their non-aspirating peers. These are just pilot data published by the wonderful Andrew Palmer out of Oregon that are the only data that I know of that actually suggest that we might improve cough using EMST in head and neck cancer populations. So I threw them into this talk here. This is a pilot study in 6 patients who had actually been treated with a supracricoid partial laryngectomy, and they identified after expiratory muscle strength training a statistically significant improvement in their cough, as well as patient-reported outcomes surrounding their respiratory function and other functional outcomes. And so encouraging data that suggests that perhaps there is something to target with cough, and that perhaps EMST might help cough in this population. Still a lot to learn and higher levels of evidence needed. There are also data that support the concept that swallowing related muscle activity is engaged during the expiratory muscle training task. So these are data again by Karen Wheeler-Hageland and colleagues, where you can see some of the physiologic action or activity that is seen during EMST. So the palate elevates and closes, as does the hyoid. And these are EMG waveforms showing submental muscle activity. Top left is a normal swallow. Here's a Mendelssohn maneuver and an effortful swallow. And what you can see on the bottom left with the EMST is that you get higher amplitudes and longer duration of activity in the submental muscles during the EMST training task than you do with a normal swallow. And that amplitude is quite similar to the amplitude that you see in an effortful or a Mendelssohn. Taken a bit further, these are data again in healthy controls. These are using EMG, but needle EMG into the muscle belly itself, showing that same concept. So here on the blue plot here, we see prolonged and increased amplitude of soft palate muscle activity during the EMST task. I just realized I think my cursor is perhaps on the wrong screen. So I'm pointing at this plot here. Compared to during the swallowing task here. And that same pattern of prolonged and increased amplitude is also evident in the submental musculature. Just an example to see what this looks like dynamically. Here you can see video fluoroscopy, patient using the expiratory muscle strength trainer. You can see the little scuba mouthpiece adapter that we like to place on the device to help patients retain it in their mouth. And during the training task, what you'll notice is palate slams shut. Here, let's watch that again. So palate slams shut up here. And then watch the laryngeal framework down here. You'll see the arytenoids lift up and approximate toward the epiglottis with pharyngeal shortening, alongside that hyoid excursion that you would expect with the submental EMG data that we just reviewed. So that's some of the background about why we consider EMST in this population, perhaps as a load-dependent exercise on swallowing muscles themselves, but also potentially targeting the expiratory force for a stronger cough. We introduced EMST into our routine practice at MD Anderson in about 2014 and 2015. And we did this with a very standardized clinical protocol, which allowed us to go back and examine our outcomes retrospectively eventually. To come up with this protocol, we reviewed the literature, we consulted with colleagues who do a lot of work in this space, like Dr. Emily Plowman and others, and we developed our initial protocol for clinical implementation that's seen here. It's very similar to the published protocols that you will read about in neurogenic populations with regard to the same training intensity on a daily basis. So a 5-5-5 regimen, that's 5 breaths, 5 sets, 5 days of the week. So it essentially equates to 25 breaths through the trainer, 5 days a week. They train at a load of 75% that's based on their individualized MEP, so 75% of their maximum strength. And they trained for 8 weeks. Now, those that are familiar with the literature in this space will recognize that that is actually a longer training interval than is often published with this device. A lot of the studies will report somewhere between 4 and 5 weeks of training. And we intentionally selected a longer training program, knowing the sort of refractory nature of radiation-associated dysphagia in so many of our patients, and not wanting to give up on a methodology too soon, just based on using too low of a training duration. In our clinical implementation, this was more of a clinician-driven model where patients return to the clinic on a weekly basis. This was to test their MEPs and help them to reset their device. We also hoped that it might increase adherence and sort of motivation and accountability. And then all patients were seen prior to EMST for a modified barium swallow study and after to help with their diet recommendations, other physiologic driven sort of therapy decisions. So because we implemented EMST in a very standardized fashion, we were able to go back after the first year or so of our experience and retrospectively evaluate real-world clinical implementation of this therapy in this study that you see reported here. And so this was published in the Laryngoscope in 2018. This was a series of 26 consecutive patients who had dysphagia with aspiration, so a minimum penetration aspiration scale score of 6 in this study, who had been prescribed expiratory muscle strength training. Some of the details that are relevant are shown here. Mostly oropharynx cancer patients, all had been treated with radiotherapy, and all received these standardized outcome measures as part of their clinical workup. So the first finding in our retrospective case series was that maximum expiratory pressures, again, that's the subglottic sort of force generating capacity that the patient is able to generate, measured with this manometer here, increased by about 60%. And this represented a statistically significant increase. Those that are familiar with the data in neurogenic populations will also observe that this is a slightly higher increase that is reported than in those populations. Patients were on average 8 years post-radiotherapy, so it was exciting to see that we were able to help achieve these physiologic gains despite years post-radiotherapy. We also examined the change in their swallow and identified statistically significant improvement in swallowing safety when measured by the DIGEST methodology, which is a rating method that we developed here at MD Anderson to grade the severity of dysphagia based on safety and efficiency, and that's based on bolus clearance through the pharynx. You can appreciate, if you're familiar with DIGEST, looking at this plot, that the swallowing impairment in this group of patients was quite severe. And this is not surprising because we know that patients that are years post radiotherapy will typically have progressive dysphagia over time, and many will develop a complication that we refer to as late radiation-associated dysphagia, or late RAD. And you can see that borne out in the distribution of the severity grades of dysphagia on digest on the plot here. So starting into the therapy, 75% of patients had grade 3 or severe safety impairment. This reflects patients who have penetration aspiration scale scores of 7 or 8, so aspiration that is not being cleared from the airway, on at least half of the thin liquids that they swallow during the modified barium swallow study. After therapy, we saw a statistically significant improvement, and specifically about 30% of patients had improved digest safety grade. What you'll notice, however, is that this does not mean that they're swallowing normalized. We still have the vast majority of these patients with moderate dysphagia, but what it did equate to was less frequent or better cleared aspiration after the expiratory muscle strength training. We did not see change in swallowing efficiency. So this again points to the role of EMST likely being in the domain of airway protection or swallowing safety, and not being in the domain of helping swallowing efficiency. This is just a snapshot of the digest tool for better context surrounding those results. So this is a method that uses a decision tree to grade the overall severity of dysphagia from the modified barium swallow study. And it's based on patterns of penetration and aspiration, as well as patterns of pharyngeal residue. And the grading aligns for those who work in a cancer environment to the CTCAE, which is the National Cancer Institute's toxicity grading method, so that hopefully there's a familiarity by your oncology referring providers that a grade 1 dysphagia equates to a mild problem, grade 2 is moderate, grade 3 severe, grade 4 profound or life-threatening. In our clinical implementation of EMST, we also had a number of encouraging sort of qualitative remarks from patients that motivated us to move forward and study it a little bit more. Patients saying things like, I'm no longer running to the bathroom to regurgitate my foods, my cough feels stronger, I feel less mucus in my throat, so perhaps that's related to better secretion management. We had one patient from Florida who came back and told us that he bought a case on Amazon and took them to a support group because he'd found it beneficial. So by that, we were motivated to study EMST a bit more in a controlled environment, and we conducted a second study, which is a prospective trial. This was a therapeutic trial that was sort of nested within an observational study where patients who were on our MBS schedule more than 3 months post radiation, who were disease-free, were offered to enroll. And if they were found to aspirate, they were offered expiratory muscle strength training on trial for 8 weeks. And we hypothesized that it would be safe and feasible to improve swallow safety or airway clearance mechanisms in patients with radiation-associated dysphagia. Some of the eligibility here, the EMST regimen was identical in the prospective trial to the retrospective study, so the same parameters that we reviewed a few slides earlier. Similar outcomes. So we examined maximum expiratory pressure using the manometer as our primary endpoint, and then secondary outcomes were related to swallowing, ratings from the modified barium swallow study, cough, measuring peak flow, and questionnaires surrounding quality of life and function. So here you can see we enrolled 30 patients on this trial. They were a median of 16 months post-radiation. So this is a much earlier post-radiation population than we evaluated in our initial retrospective series, where patients were on average 8 years post-treatment. And the vast majority were treated for oropharynx cancers. We found very high feasibility. So program completion was 87%, session attendance, I should say, was 82%, and exercise adherence was also high at 82%. And I do think that this is one of the features that, just clinically speaking, I find to be quite distinct with EMST is how adherent patients are. I think it's such a simple therapy. They get the biofeedback when they hear the little swish of air. There is the device that sort of helps to engage them. And so many patients would say things like, this is the easiest thing you've ever asked me to do. It is something that I find to be one of the simpler tasks that we can integrate into our therapy for patients. In assessing the outcomes, we were able to sort of partially validate, you might say, the prospective trial results. So we found almost identical improvement in the maximum expiratory pressures. So again, that's the force generating capacity of the expiratory system. But we failed to replicate the finding with digest safety scores improving on the modified barium swallow studies. And one thing you'll notice here is that they actually weren't starting as severe in this cohort of patients as they were in the retrospective study. We had less than half of patients in the prospective study with grade 3 dysphagia. And this likely reflects that they were earlier in their cancer survivorship and the late effects of the radiotherapy had likely not accumulated yet. Despite not seeing a change in the swallowing safety scores on their modified barium swallow study, we did observe a significant functional improvement. So what we're looking at here is the IDSI-FDS. IDSI, as many are familiar, is the International Dysphagia Diet Standardization Initiative that seeks to give us a clinical tool to help standardize both solid food diets and liquid consistencies. They've developed and validated, Dr. Katrina Steele out of Toronto, an outcome measure that links to this tool that essentially counts the number of levels of diet that a patient is recommended safe or to eat and drink. And what we were able to detect in the data here is that we saw a statistically significant increase in the number of diet levels. And particularly when we dug into those data, it was an expansion of the liquids. So patients who prior to EMST were restricted to thickened liquids after EMST were able to consume thin liquids. And for those who are thinking about the data a little bit while I give the talk, you may wonder, well, why didn't you see the change on the safety score of the modified barium swallow study? The digest safety score on the modified barium swallow study reflects how they swallow without any compensation. Compensations are not included in the grading for digest. What we found in the patients who were able to increase down their diet or advance their diet to include thin liquids was that they were able to do it because they were more effectively able to use something like a throat clear reswallow or a supraglottic reswallow. So we'd helped them compensate better for their chronic aspiration with the expiratory muscle strength training. And I think that's super important when we think about what we are expecting to achieve. And that was seen in about 30% of the patients on this trial. So I'd like to wrap up the last 5 minutes or so of this talk by walking through a case where we integrated EMST, and we integrated it as a component of care. So this is a patient who presented to our service 18 years after treatment for a T2 and 2 squam of the left base of tongue. He'd been treated with radiotherapy alone in the year 2000. He presented in 2018 and he had 26 pounds of weight loss. He was symptomatic with choking. He'd had an EGD done at home that was negative for any stricture or any anatomic obstruction. And when we evaluated him on modified barium swallow study, found profound or grade 4 dysphagia, both impairment in safety and efficiency. And I'm just going to play the video for you guys. So what we can observe here is very poor laryngeal vestibule closure. At peak of swallow, that vestibule is wide open. He penetrates the majority of the bolus and then aspirates in gross amounts post-swallow. This is a very common pattern of aspiration in the head and neck cancer population. In addition, he has quite poor bolus propulsion, poor drive by the tongue base, and poor pharyngeal constriction. Other factors in his history, he'd had no pneumonia. Surprisingly, watching the fluoro, but we see it all the time in this population. His MDADI score was 63 out of 100. That represents very poor quality of life related to swallowing. We want it to be 80 or higher. And his PSSHN, which stands for the Performance Status Scale of Head and Neck Cancer, diet level was 50, indicating that despite the severity of his dysphagia, he was eating a soft diet and not tube fed when he presented to us. He had normal range of motion and a normal cranial nerve examination on other physical exam. We recommended from this swallow study here that he continue a soft diet, start to thicken his liquids to nectar, use some strategies with those, and start an aggressive swallowing therapy program. Here at MD Anderson, we implement swallowing therapy under a framework that we call our boot camp program, and it's a stepwise progression through organizing all of those options that are on the menu into something that makes sense for us in our practice setting and our patients. It starts with a comprehensive evaluation. You just looked at some of the elements of that. Every 2 weeks, we meet for consensus, and as a team, we watch swallow studies and talk about cases and develop a therapy plan. And then the therapy plans are hierarchical. The first phase is optimization. It considers a whole host of therapies that can improve either the strength or the structure of the swallowing system. And then the final phase is functional, focused on mass practice of swallowing under progressive resistance. And often we use in this phase of the therapy, the McNeil Dysphagia Therapy Program. But for some patients who cannot tolerate bolus at all, we may start with really intensive SEMG-driven dry swallows. So the bootcamp swallowing therapy program has been described in a Perspectives article that I had the pleasure of co-authoring with Georgia Malandraki a few years ago that's on the topic of intensive models of dysphagia therapy. And one of the elements of that paper is a checklist that just sort of describes the considerations for bootcamp. And we actually use this when we present cases for consensus. On the left-hand side are all of the factors that we really think about in the planning phase. And then on the right-hand side are the therapy plan itself, starting with optimization. So these are most of the options on our menu. There might be some that are missing. It's not prescriptive fully. So dilation for stricture, Botox for non-stricture UES dysfunction. We pretty rarely use that here. Vocal cord medializations would be indicated for clottic insufficiency, jaw range of motion, Therabite style devices for trismus, manual therapies integrated for fibrosis-related decreased range of motion, device-facilitated lingual strengthening with IOP or tongue ometer for lingual weakness, and then EMST for airway protection. And I've got to say that EMST for airway protection is one of our most common optimization strategies, along with manual therapy and GI referral. So again, going back to our case, the patient started with a EMST. This was actually done as a home program because the patient lived out of state. So they self-adjusted up the training load on the trainer on a weekly basis. And this is the post-EMST swallow.
Follow. Pop. Follow.
So I'm going to pause there before we watch the solids just to say, I hope we can appreciate that this is still not anywhere near a normal swallow. Laryngeal vestibule closure is still incomplete. There's still aspiration, but what we're seeing is slightly better ability to engage in compensatory strategies like the supraglottic to advance the diet a bit. I'll move on now to show the rest of this, which will bring in a thicker bolus. That was nectar. And still very inefficient swallow. So if we look at the evaluation details after EMST, the MDADI score MD Anderson Dysphagia Inventory, a measure of swallowing related quality of life, has improved by 14 points. That's a clinically meaningful improvement. The diet level is unchanged, still a soft diet. Swallowing safety has improved by 1 grade from profound to severe, still aspirating, but not in gross amounts, and now able to compensate with a supraglottic swallow. And swallowing efficiency is unchanged. Overall digest grade has dropped by 1 grade from profound to severe, and maximum expiratory pressures have increased from 82 to 137, which is now within the normal range of expiratory force generating capacity. And the patient was now at this point recommended to continue that soft diet and use nectar or start taking thin liquids with a supraglottic swallow. The next phase of therapy for the patient is now the functional therapy phase, where we do mass practice of swallows under intensive challenge or intensive load. For this patient, they are bolus able, and our vote for that is almost always going to be the McNeil Dysphagia Therapy Program, which is what he did. He came to Houston and spent 3 weeks with us, and this is his post-EMST video, and this is actually 5 months total after his initial presentation to us with late rad. So definitely not a normal swallow, but again, meaningful gains. So at the end of his journey, his MDADI scores have moved from 63, which is poor, to 83, which is in our optimal range. That's his quality of life as it relates to swallowing. His diet has improved from a soft diet to a full diet, 50 to 100. His swallowing safety impairment has improved from profound to moderate. It's not a normal swallow. His efficiency has improved from severe to moderate, and his overall swallow dysphagia severity is now from profound to moderate. So we haven't normalized the swallow, but we have improved the safety and efficiency. We've improved the function and the quality of life. He's better able to compensate and adapt to his chronic dysphagia. When we try to dig into what's improving, and particularly in his case, we were able to identify that it is laryngeal vestibule closure. So what we see here is the peak laryngeal vestibule closure, airway wide open prior to therapy. Post EMST, it's getting better. He's now achieving partial closure of the vestibule. And after the complete therapy program, including McNeil Dysphagia Therapy Program, not every swallow, not every time, but he is sometimes able to now achieve even full laryngeal vestibule closure. So this is a great example of the most frequent way that we integrate EMST into our head and neck cancer practice right now. There are some ongoing efforts. This is a great trial that's running in Europe right now that's looking at proactive versus reactive use of expiratory muscle strength training. And there are other uses being described in head and neck, including for voice as well as total laryngectomy populations. So I'll conclude at this point to say that we know that head and neck cancer patients risk aspiration pneumonia, particularly after radiotherapy or chemoradiation, and that EMST may have a role in optimizing airway protection for head and neck cancer survivors who are experiencing radiation-associated dysphagia. The sub-bullets on this second point really show the body of evidence that we have. EMST is feasible and safe. It can improve the expiratory force generating capacity for patients. It can improve elements of swallowing function, either functionally speaking or in some populations. We can see that actually represented in physiologic change on their video fluoroscopy. A real advantage to EMST is the adherence that patients report to the therapy. And there are other uses or indications that we didn't have time to cover in this talk that probably merit their own session in this webinar series. There are lots of questions remaining. I am curious to see the role in prehab. I think there are lots of questions surrounding the optimal dosing and duration, and also safety considerations. You know, we have a lot of patients with carotid stenosis, with osteoradionecrosis of the jaw. And so these things must be considered in our selection of the right patient for EMST. But with that, I will stop my screen share. I look forward to a couple questions and also to Katrina's talk. So thanks so much again for having me.
Thank you so much, Dr. Hutcheson. That was amazing, and I'm definitely feeling smarter. We have just a few questions for you before we have to move along.
Of course.
First, do you have any requirements for initial scans for clearance prior to starting use of EMST for patients who may have potentially unstable carotid vasculature?
That's a great question. I would say, I think that came from Josh. Hi, Josh. I don't know. The short answer to that question is no. We don't recommend a particular evaluation protocol. I will say that our standard is for any patient who has carotid stenosis, and those familiar with the particularly late RAD population know that it coexists with dysphagia a lot. Those patients, we get clearance from whatever cardiologist is managing their disease. So yeah.
Great.
Same goes for patients with active osteoradionecrosis of the jaw. Particularly if they have osteoradionecrosis in trismus and they're going to be struggling to insert the mouthpiece into a fragile jaw. That's a population where we'll take it to the surgeon, we'll have a conversation about risk benefit, and in some cases we won't recommend it.
Perfect. And how soon after starting radiation treatment do you recommend beginning EMST? And how would you implement this in the acute care setting?
Great question on both. We tend to evaluate our patients. We take a very sort of proactive approach to therapy during radiation and see patients from pre-treatment through their radiation. That's typically with sort of standard non-device facilitated exercise and eating-based therapy. The first time at which we try to really ratchet up more intensive therapy is usually around the 3-month mark. Patients at that point have had their scans. We know their disease status. We expect that their mucositis is resolved enough that their pain is under control to do stuff that's a little bit more intense, like inserting a mouthpiece. And so that's generally about as early. It's not to say we never would consider it, but yeah. Acute care, I'm not sure if you're talking about in the head and neck cancer population, acute care, or more broadly in acute care. We use EMST a lot less in our acute care setting, but there are folks that use it a lot in other populations. Brooke Hutcheson has tons of experience in educational series in this space.
And I believe this is in reference to the DRS 2019, Hutcheson et al. Were the patients included in the study participating in other swallowing therapy protocols or only completing EMST?
So during the prospective trial, the therapy was we were a lot better able to control for co-therapy, and those patients were doing EMST. If patients were already doing their sort of prophylactic, Masacos and things like that, we didn't have them stop, but we felt pretty confident that there are good data to suggest that those exercises in and of themselves were probably not going to be giving us big functional gains that were a confounding factor.
Okay, great.
Yeah.
And is there any data of doing MDTP and EMST?
That's a great question. We get this question all the time from a practicality standpoint, because, like some patients are, they're a captive audience and you want to do as much as you can for them all at once. I don't think it's wrong to do it all at once. The model that we have of doing EMST or other optimization therapies first, followed by more of a functional therapy, is that idea that let's get them as set for success as possible before we spend 3 weeks every day. That's a lot of time on our end. It's a lot of time on their end. So let's give them the most likely scenario of achieving maximum success from MDTP. That said, of course, we have patients who sometimes come and we do maybe 4 weeks of EMST and then they start MDTP halfway through our program. It's not prescriptive, it's patient-centered.
Okay, great. And final question, did your patient have significant fibrotic cervical tissue?
Oh, are you talking about the case?
I believe so.
Probably the case. Yeah, absolutely. That's a great question. Cervical fibrosis and also cervical posture abnormality, head drop phenomenon that frankly we think probably promotes aspiration of residue down into that airway, things like that. Those are very common in patients who are presenting back with late RAD. And one of the other optimization strategies that we use a lot, and particularly now, is manual therapies. And that would often be done simultaneous with the EMST or other optimization strategies. Yeah.
Perfect. Thank you so much. We really appreciate your time and for sharing your knowledge with us.
Oh, of course. Thanks for having me.
Have a good evening. And we are going to move along now to Katrina.
Hi, everyone. It's nice to have you. I looked over our participant list, and it's exciting to recognize some names. Today, I really want to emphasize we're going to be talking about lymphedema. And traditionally speaking, I think this is a topic that speech pathologists have tended to not necessarily address first line, look at it as perhaps this isn't my wheelhouse. This is not my area of expertise. This belongs to somebody else. And so I really want to focus today as we talk about optimizing head and neck survivorship in this arena on SLPs taking that forward role and becoming more active in the management of this chronic progressive disease state in this population. Those of you who know me know I'm technically challenged, and so I've handed my slideshow over. Could I have the next slide, Gail? Thanks. Okay, so what are we going to be talking about? The head and neck cancer demographic. This has changed tremendously over the last decade or so in particular, where previously, when I first graduated 20 something years ago, they told us, oh, head and neck cancer, that population is going to die away. Nobody's picking up smoking from, as a teenager and continuing on. Those people are dying out. But what we've seen is a change, and we're going to talk about this more. And patients are developing cancer at earlier ages and therefore having longer lifetimes, and long-term survivorship becomes very important. And that's an area we don't really understand. We haven't had enough of these patients with 30, 40 years of survivorship to understand what that looks like after our traditional treatments. So functional deficits, those of us that work in the head and neck cancer population understand that there are significant functional deficits associated with cancer treatment, whether it's surgery, radiation, combination of both. And the important thing to remember is that so many of these functional deficits can be both latent and progressive in nature. And so it's very important that we maintain constant contact and observation in this population so that patients are able to optimize their functional status long-term. And we're going to identify treatment pathways to make sure that patients really are managed well in the long term. So the changing face of head and neck cancer, let's talk about this. HPV positive tumors disease is now the majority of new oropharyngeal cancers that are diagnosed each year. Think about that for a second. Those of us that have worked in head and neck for a while understand this had previously been a largely addiction-based disease state. Prior to 1995, we were seeing patients 6th and 7th decade of life. We were getting 60, 70, 80-year-olds with, traditionally speaking, and the majority of, but not all, tobacco and alcohol-related disease states. Now the majority of diagnoses are 4th and 6th decade, 4th to 6th. Think about that. So we've got 40-year-olds. Our cure rates are better with HPV-positive cancers, so they go on to lead a typical life expectancy. We're looking at 30 and 40 years of survivorship. And we're really not understanding well what it looks like 40 years after radiation treatment. So maintaining contact, and this is something you're going to hear me say repeatedly throughout the lecture tonight, is super important. And as an SLP, our role in that and advocating for our patients is of primary importance, particularly when it comes to certain elements relating to our outcomes. If we're dealing with dysphagia and swallowing issues, how is it we're mitigating these over the transgression of what is typically a swallow decline associated with aging, and added to that then the effects of head and neck cancer treatment. So what we understand also is HPV, and patients ask us this constantly, well, where did I get it? When did I get it? How did I get it? That kind of thing. And according to the literature, it's reported anywhere from 10 to 30-year latency between when the HPV exposure occurred to the evolution of disease. Patients are surviving longer. So typically we would talk about 20-month survivorship, patients doing well. 131 months, that's a whole lot of time for patients to deal with the effects of their treatment. And so we really want to focus on optimizing not only function, but identifying the pathways to make that happen. The next slide. Okay. Minimizing treatment implications. This is something that we try to focus on a lot here at the center. And I'll get into that a little bit later, but if we can minimize our treatment implications, that translates into fewer functional deficits that we're having to manage on the rehab side. And optimizing functional status following treatments, obviously, that's what we're all here to do, and make sure that that happens long-term when we're talking decades of survivorship. Next slide. Okay, so what I'm showing here is our protocol at the center, which has evolved over years and years, but it's with an understanding that there needs to be consistent monitoring of these patients post-treatment, even after they're considered cured from their disease state. So we start with prehab, right? Radiation counseling. We do a lot of focus and it's on preserving function. So it starts with baseline evaluations, but we're also educating patients on what they can do to optimize their outcome, not only during treatment, but understanding that what happens during treatment has implications following treatment, ongoing into their survivorship. The clinical evaluation, we do that 3 weeks into treatment or thereabouts. We try to get them to understand what sort of challenges are they having in following the protocol, and is there anything we can do to mitigate some of that or help them succeed a little bit better during the treatment itself? So we do our first fees, and we do fees here predominantly because we work collaboratively with the ENT surgeons. And so they like the surveillance element, having an extra set of hands and eyes on these patients all the time on intervals that are different from their exams. So 3 weeks after treatment, we're looking at them with the fees. 6 weeks later, we're looking at them again. If everything seems stable, then we don't see them again for 4 months. And again, if that's the case, 6 months. And that continues until they're no longer around or a patient. It's forever. And that is because the latent effects of treatment are real and progressive and also very gradual. So it's difficult. And I explain to patients, it's not that I don't trust you deciding to tell me when you're having issues, but it can be like watching your hair grow in the mirror every day because the changes evolve so gradually, and you're living with your swallow every day. You're not aware of anything until that functional change becomes significant in nature. So when we talk about lymphedema, and this is a subject, this is very basic in terms of the educational understanding, but I think it's important to understand before we can talk about how it impacts functional outcomes. So lymphedema itself is lymph fluid buildup in the tissues that causes swelling and can lead to fibrosis long term. So 1/3 of the body's lymph nodes and circulation actually is very rich in the head and neck area as well. And so if you think about surgery and radiation as disruptive not only to circulation, but also the scarring that evolves as a result of these interventions that can impact circulation and function. So the impaired lymphatic drainage leads to swelling, and patients often refer to it as specific swelling. And if they're post-op, it's natural for them to think this is just swelling from surgery and not interpret it as, in fact, lymphedema. So there's a lot of education that goes along with sort of discriminating the difference between surgical inflammation versus lymphedema, and how that needs to be mitigated down the road. So long-term lymphedema, especially untreated, can lead to increased fibrosis, stiffness, and other issues, and we'll get into that further. So let's look at this slide. I love this image here, this graph. What we know, these are in patients 12 months post-treatment. 90%. So if you can see that gray area, that represents 100%. Look at the navy blue area. 90% of patients have lymphedema of some sort. And the small blue area that looks smaller is almost 50%, 47% have moderate to severe fibrosis. 75% lymphedema cases are moderate to severe. This is a significant issue in this population. So it's very important we understand, especially if we're held responsible for optimizing functional outcomes, how lymphedema can impair and impede our ability to improve on those. On the next slide, so the signs and symptoms of lymphedema. Oh, this is the wrong deck. Okay. The previous, there you go. Okay. So per the American Society of Clinical Oncology, well, and anyone who also works with these patients can agree that these are very common complaints from patients post-treatment. So pain, discomfort, tightness. How many patients on a constant daily basis report of tightness and constriction, reduced range of motion, the scarring, the woodiness in the tissues. When patients say, oh my gosh, my neck is just so hard, it can translate into difficulty breathing. There can be obvious swelling, both internal, and we'll talk about the difference between these two, but internal and external. Resonance changes and voice changes or difficulty speaking, especially when lymphedema impacts the lips and the tongue. The next slide. Okay, so let's talk about the varied phases of lymphedema. The picture on the left, I'm sure we've all seen, or many of us have seen before. This is very, very severe case of lymphedema. And this is an earlier stage. The earlier the stage of lymphedema, the easier it is to reduce and mitigate. But the important thing to understand is that regardless of the stage, there needs to be ongoing management. It's not sort of thing, well, we'll get them, quote, deflated and then they're better. It'll just become a recurring problem unless you have consistent management. And then on the right side, this is actually a patient from our clinic, much less severe, but still he was so bothered by the distortion in his appearance from his lymphedema. And his complaint was, I finished therapy so long ago. Why isn't this any better? I don't understand why it's not getting better. And so a lot of education goes into play in this population as well, so that they understand not only the manifestations that are possible, but then on down, once we've identified management strategies, their role and responsibility in that as well. The next slide. So lymphedema screening, and here we've got an example on a CT. This can be done with CT, MBS, or endoscopy. So on the CT, the picture on the left, if we're looking at the submental soft tissue region where it's marked 1, it's typical contour and the epiglottis, and then we see the posterior pharyngeal wall or prevertebral soft tissues, pretty typical presentation. And then we look 7 months post-treatment, the image on the right, and you see there's submental fat stranding, there's significant change there. The epiglottis is now thick and more blunted. There's been more effacement of the vallecula, and the prevertebral soft tissues and posterior pharyngeal wall thickening is much more significant than previously. So, and this is just within 7 months. The next slide. Now, these are pictures from my clinic. So a lot of these you'll see, and I try to make these relatable, but these aren't just sort of textbook cases. These are things that we've encountered specifically and had personal experience with. So internal lymphedema on the left, this is laryngeal, and you can see the vocal folds you can barely visualize. It's just sort of a big puffy structure. It's very difficult to identify. The actual arytenoid cartilages are more distorted. The epiglottis, you can see, actually approximates now those arytenoids and the puffiness. Now, this patient has a viable airway, believe it or not, but there are cases where that isn't as pronounced glottic aperture. And I've got a picture of that later. So on the right, we've got more diffuse pharyngolaryngal lymphedema. And you can see there's epiglottic distortion if you look at the left pharyngeal wall. There's some reduction in the pharyngeal space. We see diffuse laryngeal edema, especially in that postcricoid and interarytenoid area. And all of this can implicate not only, obviously we're concerned about breathing, swallowing, and as well as voicing. So the next slide. Oop, back one. There we go. So this is a great example of untreated lymphedema and the progression, and rather swift progression, that can happen. The picture on the left is an initial presentation to us. We hadn't seen this patient previously, and he came to us 6 weeks after radiation completion. Normally we keep a little closer eye, but this was our first baseline of it. We had advised lymphedema therapy. He wasn't able to access it. 8 weeks later, he comes back, and this is the progression we see. So you can definitely see not only in the interarytenoid posterior laryngeal region, but also the epiglottis now is even thickened. This translated for this particular patient into a significant change in his swallow ability. So if we're talking about optimizing swallow outcomes, lymphedema is in the way here. And this is where speech pathologists are typically the frontline, very first level of rehab in this head and neck population. So identifying not only the presence of it, but also the implication to your functional outcomes is critical in optimizing their outcomes and your ability to improve on those. Here's another example from the SLP perspective. This is obviously a laryngectomy patient. We had seen him initially post radiation treatment, and he had presented with mild lymphedema, a little bit of swelling, mostly in the jowl area. And when we did his initial prosthesis placement, and he came back, this was about 6 weeks later, and you can even see there's tissue breakdown at the level of the skin. He was seeping. There's no longer, he came in with complaints of difficulty breathing. You can see why. But the lymphedema had completely overtaken not only he was complaining about his quote blockhead, but it had compromised his airway at that point. He ended up needing to go back for surgery, and because the dermal breakdown, and actually his whole incision ended up coming apart. So this is something to identify. And he wasn't scheduled to see his ENT for another 6 to 8 weeks, something like that. So this is something where we identify, whoa, you need to be seen sooner. All right, treating lymphedema. Now, this is where it comes into play. We're not physical therapists, but this is still very much in our wheelhouse. Care pathway priorities, even if we're not the ones actually doing the manual lymphatic drainage or massage or anything, being able to facilitate patient access to care. Now, we have patients that come from all sorts of different areas, sometimes hours and hours away. So we have to allow for proximity, time, and cost. I saw a patient today. He was concerned about coming to Fort Worth for, therapy. How frequently? I said, no, this is something that we're going to set up close to where you live so that this is something you can do consistently and actually receive that benefit. And time and cost are another thing. Right now, I've got patients where cost is a big thing. The price of gas is not low, and driving a distance for therapy can be consequential to their monthly income. So we've got to look at all these factors when we look at what's the best modality for that particular patient. Routine surveillance visits to address, reinforce, and educate. As I said, in our practice, we make sure that patients are on a set protocol of surveillance and observation. And at each visit, we're looking and screening for changes, not only on the functional side, but also how are things feeling? How could, is there any pain anywhere? In noticing their range of motion, we're taking baselines when we first see them, and then noting any change or progression that we happen to see, even if the patient's not noticing anything themselves. So in educating patients, this can be, and typically if they're noticing anything at all, a progressive issue. And so we need to identify things for them to look out for so that they can facilitate. I'll say, okay, I'm making an appointment for you in 6 months, with the caveat every time that if you notice something, I need to take a look sooner than later. Don't just wait until that 6-month visit. And make sure they understand that the goals are accomplished at home when it comes to lymphedema. This is something that takes consistent effort at managing, and adherence to the therapy plan is key. And patients a lot of times look at it as like, oh my goodness, it's one more thing I need to worry about. But the way I try to explain to patients the whole process of their cancer disease state and then the sequela of treatment after, they don't have a lot of control over. So things are being done to them. The changes that are happening during radiation, they don't have control over. Things are getting worse every day and they don't have control over. This is something you can say, you've got control over this. This is something that you can do to fight back and get back. That's and that self-empowerment can be very powerful in terms of motivating them. So home-based plan with self-management methods and tools is essential. I can't say that any better. And then episodic in-clinic care cannot be used as a primary management strategy for a chronic disease like this. So that's another thing, that even when we send patients for lymphedema therapy, I try to set up the expectation that this is designed to improve your lymphedema for sure, but this is something that will come to an end. And at that point, it's going to recur progressively. And without your own management and maintenance at home, we're not going to get good control over, so that they understand very much so that there's responsibility on their end. It's not simply going and to therapy and then everything's better and it's all over. This is a chronic disease that needs to have chronic management as well. Okay, so let's talk about the FlexiTouch Plus for head and neck lymphedema. So this is a new application. Now, it's been used in the arena of lymphedema for years, but has more recently been approved for use in the head and neck population. And honestly, it's been a godsend for that reason, that self-maintenance on an ongoing chronic basis is key. And that can be very difficult when it comes to traditional methods of care. So this has provided a nice little arena where patients have optimized their own management of this at home with minimal investment. And I'll get into that later. So it's dynamic pressure to stimulate lymphatic function. We've got a video that sort of demonstrates how this works. It provides patients a home tool for daily management. It only takes 32 minutes. So what I tell patients is, you put it on, you turn it on, and you can do something else. You want to watch the news, watch TV, read the paper, do something else, but it doesn't necessarily involve carving separate time out of your day. And in that sense, I feel like we've had a lot more success with patients doing home management in a successful manner versus really trying to carve out time for manual lymphatic drainage techniques they've been taught, the compression things. This is something that really minimizes the impact on their day-to-day routine. And traditional techniques, I will say, we still will talk about compression and massage and manual lymphatic drainage, but this really does provide a tool where maybe patients don't have the time to do all of that, or, oh my gosh, the compression, I can deal with that a couple nights a week, but every day. This is not to exclude any of that, but use it as another tool to optimize their outcomes. And the next. Okay, so this video, and Gail, I'm going to ask you to run this for a few times, 2 or 3 times, but if you can see, the air chambers are serially inflating. And what that serves to do is sort of mimic the effect of the massage, the manual lymphatic drainage massage that they would receive at the lymphedema therapy sessions. And again, this is done at home and with minimal impact to their ability at that time or need to carve out separate time from their routine activities. And it's gentle, I will say. This is not uncomfortable. I've not had patients complain about anything. I was anticipating a little bit perhaps of a claustrophobic, but I really haven't had patients reporting any effect that way. All right, and the next slide. Okay, so in the first randomized controlled trial of home management for head and neck lymphedema, this study was done at Vanderbilt. It's the first of its kind, and I just love this. They looked at it reportedly here, swallowing solids, pain level, and then the degree of external swelling. So when we look at swallowing solids, the lymphedema traditional methods group had some improvement, but the patients that were able to use Flexi Touch that had 4 times greatest swallowing. So if we look at everything, traditional self-management requires some dedicated time set aside. And for that reason, it's not to negate a patient's willingness or desire to do anything, but sometimes life can get in the way. And so compliance sometimes isn't as great as even the patient would hope it would be. Whereas with the Flexi Touch, because there is minimal impact on their daily routine, they're able to be a little more compliant and in that sense, achieve a little better outcome. The level of pain in the self-management group actually increased while it remained stable with the Flexi Touch group. And external swelling increased with the self-management patients versus 24% experienced a decrease in the external swelling. And I think this speaks to a wide array of patients, regardless of their desire or motivation. But if they understand, hey, this is what we understand. If you can put this on every night while you watch TV or read the paper, get ready, your normal, make it a part of your normal nightly routine. Look at what potentially is possible. And the next slide. Okay, so here we have, this was one of our patients. We actually sent him from our office to the hospital where he was trached. So on the left is the day of the emergent trach, and I know there's some shadows in there, but you can see there's very little glottic aperture, and the patient did come in reporting complaints of dyspnea for several weeks at this point, and we had talked to him about different methodologies. He tried everything, and his lymphedema at this point had become too significant. He did not want the trach, but he really wanted to breathe, so he didn't fight us too much when it came time. It's time for the trach, and we were able to get him the Flexi Touch 2 months later. The picture on the right says everything. He was able to be decannulated. And I think this speaks volumes when it comes to successful intervention. And when it comes to airways, patients, I don't know how many trach patients you've worked with, but trach patients do not like being trached. The idea of being decannulated is their primary solitary goal, if at all possible. And in 2 months, we were able to decannulate him as a result of his improved lymphedema. And the next slide. This is a very extreme case, but still no less telling. This is a post-laryngectomy patient, and he presented with a significant amount of external lymphedema, but not to the degree that he was reporting a lot of discomfort. It was just for him. He had a very square head, face, and it eliminated his actual neck space. He had sort of a head against his shoulders. Internally, however, he was complaining of significant difficulty swallowing. And so when we looked inside, as you can see, there's no recognizable structures. Those of you who are accustomed to scoping the laryngectomy patients, there's no larynx, but there's still a very clear anatomical feature, and we don't see any identifiable structures here. He had one treatment with the Flexi Touch just to see if we could improve anything. And you can see the picture on the right, what a significant difference there is. So he was sold. This was definitely a lifesaver for him. And I was shocked and I'll be very candid, I have done pre and post trials, but this was definitely the most remarkable change that we'd ever seen. And the next slide. Now, these are external results from the FlexiTouch, and this is, again, one treatment, and these were conducted in the office. All of these patients were greater than 18 months post-treatment. And what I will say is that lymphedema is definitely more reducible the earlier the onset that we're able to do the intervention. So the earlier the stage of the lymphedema state, the more amenable to reduction that it is. It doesn't mean that it's not worth doing. Let's say they're 5-6 years post, those patients still appreciate an improvement in optimization, but it won't be as significant or quick as the earlier stage post-treatment patients. So the first patient on the left, he was 4 years post-treatment, and his target was base of tongue. Radiation neck dissection. He didn't like his jowly appearance, and after one treatment, you can see on the right, he had a significant reduction in his jowls to where he was happy. He's not smiling there, but he did smile. And in the middle patient, this patient he actually had cancer once, and then he experienced a recurrence. He ended up with a secondary neck dissection, radiation, and he's about 18 months after that. So he, again, had a very pronounced jowl line that he did not like. And the picture on the left, especially you can see in his lip area region, and he took his glasses off for the second, but it was displacing his glasses. And after treatment, he no longer had the same puffiness. He was really happy with how his glasses fitted, and he particularly liked how his lips were looking. And on the far right, this patient was actually 7 years post-treatment. Never really liked his appearance after treatment. It was, again, base of tongue. He underwent neck dissection, radiation, and he wasn't in this frame or sphere of severity. He wasn't what we'd consider severe, but for him, it really bothered him. This was not his typical appearance. And after one treatment, he was very, very happy with having his old face back. The next slide. Okay, so inside, what's actually happening? These images show infrared fluorescence imaging, where if we look at the picture on the left, this is dysfunctional lymphatics. So you can see sort of a foggy appearance, and that's lymphatic fluid that's actually just sort of trapped and sitting. There's no active lymphatic flow or any pathway for flow. On the right side, we see functional lymphatics, where you actually are seeing the nodes and you see critical pathways where there is drainage. We don't see that boggy or foggy look within the soft tissues. And then next. All right, so this was a FlexiTouch trial, and I love this. They basically took a baseline image. They did one FlexiTouch, the image again. Then the patient conducted the FlexiTouch treatments for 2 weeks, and they did the final image. So all the patients showed improved lymphatics uptake with a single treatment. And you can see from my own images that a single treatment can be very demonstrative to the patient too, in terms of why this is important. But we look at this particular patient. If you look at visit 1, which is top, I'm not sure if you can see, it's kind of small, but picture A on the left, he's got reduced dermal backflow. You see more of that bogginess. And this is looking at a lateral image on his neck. So the next one on the right, upper right, that's from the front, same day. And you still see some bogginess. We don't see clear pathways anywhere. There's that generalized foggy lymphatic backup. And then visit number 2, after 2 weeks, they re-imaged, and now you can see in those same images. So if we look top to bottom, this is the same view. Now you can see more direct and dramatic lymphatic flow. And on the right from the front, you actually see very significantly improved lymphatic flow where it looks as if there have been new lymphatic pathways developed and established. So pumping left to right toward the healthier tissues. And that's one thing I really encourage with patients is that they understand with continued utilization, the body develops alternate pathways or detours around the blockages so that you do get better lymphatic circulation overall. And the next slide. Okay, so this is a lot. Basically, what I want you to take away is the lighter is before FlexiTouch, the darker bar is after FlexiTouch. So if we look at the graph to your left, to the far left, what we're seeing is 0 on the poor, 5 excellent. So the higher it goes, the better the rating. And this was ability, I can't even see it. It's a little blurry on mine. But they looked at swallowing, pain, range of motion, and overall lymphatic appearance, so the external swelling. In each case, though, what you're seeing is left pre-FlexiTouch, right post-FlexiTouch, and the group experienced improvement with the FlexiTouch device. And it was after, this was 90 days of reported utilization. So in the next slide. So in the NCCN guidelines, we're calling for more proactive consideration and intervention. The recommendation for survivorship guidelines, and this is new, so a lot of these have been there. So early detection diagnosis is key for optimal lymphedema management. And again, identifying patients in earlier stages when they're more responsive to management is critical. Screen survivors on an ongoing basis for swelling, feeling of heaviness, fatigue, fullness at each visit. And another thing to look at is any degree of trismus, because lymphedema within the mandibular region, parotid region, can significantly impact jaw opening. And so trismus, you've got a patient reporting fluctuating ability in that regard. It's likely a function of lymphedema, and that can be a signal that this is, as much as it may not manifest externally to where you think it's significant, if they're reporting, hey, some days I can open my mouth a lot better than others, it's probably impacting that on a functional level. So provider education and recommendations, and this is very important, I think, and I've stressed this a lot, but educating your patients is crucial. They need to understand the importance of what it is they're doing and what it is that's happening. A lot of patients, and we all know this, patients will say, it's not bothering me that much. I don't really think it's worth mentioning. Stress the importance of reporting anything, even if it's milder, they don't consider it bothersome. So like the degree of jaw opening, or patients saying, hey, some days my speech is clearer than others. I feel like my tongue sometimes swells up and sometimes it goes away. I don't think it's anything I've eaten, but I can't tell. All of that's very important to help identify when there is a lymphatic process going on. So consideration of compression garments, MLD, the manual lymphatic drainage, and pneumatic compression for ongoing home management. And this is what's new in their guidelines and really nice in terms of recognizing the value and utility of this particular tool in the ongoing management. Physical activity and supervised resistance training can also improve symptoms. And what I'm noticing more and more frequently is that we used to think of it as a one or the other. Well, we'll send patients for lymphedema therapy, or we'll get them a pump. And our lymphedema therapists are now, and we don't have any here at the center, so we're making outside referrals. And what I'm noticing more frequently is that these therapists are actually saying, hey, you should also look into getting the FlexiTouch to continue the benefits of what we're actually able to achieve here in therapy. So it isn't necessarily a one or the other. There's a lot of collaborative benefit from the modalities. And the next slide. Okay, So now we know what it is and what it can do, but how does it fit into our protocol? So obviously we do prehab, they have their cancer treatment, there's supportive care. 0 to 4 weeks post-treatment is typically when we'll see them the first time. And should there be any deficits, that's also when rehab begins. So 4 to 12 weeks post-treatment, between that first phase and the second one is when we tend to see the significant development of lymphedema. Whether it's severe or not, they typically aren't presenting with much at that third week post-treatment unless there was some present as a post-op sequela. But from a radiation standpoint, we're not seeing it at that 3-week mark. 6 weeks later, we take a look, and lo and behold, oftentimes there's been a significant change in that way. And that's where we will refer for FlexiTouch or for home management. And again, it's much easier to treat the earlier the onset it's identified and then mitigated. And then 3 to 6 months post-treatment is when we're seeing ongoing and managing, depending on, and reinforcing too the importance of maintaining their own home program. Not that this isn't the kind of thing you tuck under the bed and don't use. This isn't the kind of thing you pull out once a week. This is the kind of thing that you need to keep and make sure you're using on a daily basis, especially if we're noticing at those follow-up visits that things have changed. Are you using your FlexiTouch? Well, not always. Okay, this is something, let's get back on board. Let's try using this more consistently and see if we can see a change. And the next slide. All right, so varied institutions, this is where there can be challenges, and I recognize that. I was hospital-based for years and years. Developing facility clinical pathways and interdisciplinary protocols is key. You know, every hospital is going to be different. You're going to have different obstacles in terms of collaboration and interdisciplinary care, but I think the importance is educating and understanding, hey, you might be working with the physical therapist, you might be working with the ENTs, you might be working with PM&R, but understanding there's a role and position for everyone, and the SLP is the primary first line rehab professional in this population. Typically, your role in that regard is key. So private practice established interdisciplinary collaboration with underlying and agreed about clinical pathway protocols. So, you know, we collaborate with the Head and Neck Cancer Center of Texas. The protocols that we utilize are valuable on both ends. And so making sure that there's an understanding in that regard of not only how it values from our functional surveillance element, but also how it can improve upon the surgical side and cancer surveillance side, disease state, can be valuable to allow for improved collaboration that way. And find ways to streamline the referral process. That one's huge. You know, in this day and age, insurance can be a significant obstacle. And so just understanding the best pathways and allowing patients to become involved. If they need to get a referral from their primary care doctor, make sure they understand, hey, the quicker you can get that, the quicker we can actually facilitate this. And a lot of times patients then also take an active participation. There's value added to that care. And managed care, I worked in a VA setting for years as well. So establishing institutional clinical pathway protocols, and this can be then lateralized across facilities as well. And prosthetics department is invaluable when we're talking about a FlexiTouch acquisition, and system-wide implementation would always be a goal in that regard. Okay, and the next slide. Okay, in summary, obviously it takes a village. We are the speech pathologists and a key player, but it's not all us. So we've got to have good interdisciplinary relationships, pathways, referral sources, and communication for sure. Current disease trends and treatment efficacy mean decades of survivorship, and it's important patients understand, and I stress this all the time, as much as you might be 11, 12, 13 years post-treatment, it's still important that we see you on a routine surveillance protocol so that we're able to identify changes that can impact and help maintain optimal function long-term when we are looking at decades and decades of survivorship now. So ensuring optimal quality of life following treatment is the responsibility of the entire team of interdisciplinary specialists. And as SLPs, oftentimes we're the one at the head of that functional element. Untreated lymphedema can have a significant impact on functional abilities following treatment. And when we're tasked with optimizing those, we need to be able to identify when that is interfering with us being able to achieve optimized outcomes. So establishing protocols for disciplinary collaboration ensures optimal identification, management, and outcomes. Here, once we identify lymphedema, we simply make the referral outward in whatever direction it's going. The physicians always are behind us. It doesn't matter as far as they're concerned within our sphere. This is more our wheelhouse than theirs, believe it or not. So if we identify it, this is what we think needs to happen, they're all on board. And empowering patients with self-management strategies and tools can make all the difference between success and failure. We all know when it comes to patient outcomes, motivation on their part is huge. And oftentimes head and neck cancer comes with a very tremendous psychological burden that can be difficult to overcome, especially if we're trying to incite motivation toward things. So I think education and understanding that there's an empowerment involved when they start to fight back from the effects of their cancer treatment, that can be tremendously effective in not only changing their outlook, but then translating into how much they are involved and in their self-management and ongoing self-management. And the next.
I mean, I joke about the fanboy thing, right? I'm a 49-year-old fanboy of the FlexiTouch system because it's benefited me so much. It's a tough process, cancer. As everybody said, a big side effect is going to be, lymphedema. I run one cycle on that, 42 minutes, is worth 3 weeks of manual massage, not keeping up with it and having to go to the ER. That's what this thing does for me. It's become a really critical piece of my daily life and existence, and so I'm very grateful to have it.
Okay, so I will say, he said 42 minutes is 32. That's the only thing. I love that, but it's 32 minutes, not 42. Okay, and the next. And I will say, those of you that know me very well know that my husband is actually a head and neck cancer survivor, and no, he was not a patient. That's a whole other wheelhouse, but he does have his own FlexiTouch and maintains his own self program at home on a less consistent basis sometimes, but unfortunately he lives with me, so I kind of have to kick it back up a little bit. And I hope this has been valuable in terms of your understanding and empowers the SLP to take an active role in lymphedema management, advocate for your patients, and help optimize the functional outcomes that we strive to achieve on an ongoing long-term basis. Thanks, guys.
Thank you so much, Katrina. We are going to take just a couple of questions and then I'll pass it back over to Jenny. So we had some really great questions. The first one I'm going to start with, Katrina, is there anything that you have seen or done in your clinical practice that helps with internal edema?
So that's a great question, because honestly, before the FlexiTouch was out, it was one of the most difficult things that we found to treat. So we would send patients for lymphedema therapy, and in some cases we'd see a mild reduction, but we really weren't able to see a tremendous impact in that regard on an ongoing basis. Now, there might have been some significant reduction at the time of treatment, but again, if patients aren't self-managing at home, we weren't able to see that, and we would describe it to patients like, I wish I could get in there and massage it out of your larynx the way they can out of your external soft tissues, but we just weren't able to do that. And with the FlexiTouch, you can see we've had some profound results that way.
Katrina, I'm going to ask you this because we get this question frequently. When you say that you're getting these results with FlexiTouch, are you assessing that with a modified barium swallow study, with fees, with video strobe? What does that look like?
So we use both fees and video stroboscopy, depending on, what the particular issue is that we're addressing, but we do direct endoscopic evaluations. I'll also be able to interpret. We do some modified barium swells, but from a disease state perspective, we've always done the direct visualization.
Wonderful. This next question is also pretty common. Are there any contraindications in treating lymphedema with compression or advanced pneumatic compression for patients who have a new or suspected recurrence of cancer?
Yes, for sure. In fact, we typically will refrain from doing anything aggressive in terms of lymphedema management if we know there's active disease or a strong suspicion of recurrent disease that way, in order to help contain it. Compression's fine. Compression is the one thing that we do have in the Wheelie House, but any active manual lymphatic drainage techniques, those are the ones that we try to avoid.
Next question is, how successful have you been in getting your physicians to sign on to, quote, lymphedema instead of saying it will get better with time? This person has a resistant crew where they live and wants some advice.
Okay, throw some research in front of them. No, I think some of the best things you can do perhaps is sort of these before and afters that I've shown you. If you can put that in front of them, perhaps that will help convince them, but I'm not sure where they're getting, it'll get better with time, because this gets worse with time. So I think it's just a matter of educating, perhaps on a gentle nature, depending how open they are to instruction that way. But pictures tell 1,000 words, and this is no different. I think if you can show, hey, look at this, and especially if you've got a patient who's more long-term where it hasn't gotten better in time, they're 18 months post, and let's see if we can evoke some change and look what happened. That could be convincing in that regard.
The next question is, what frequency of follow-up with patients are you currently using, and how successful are you in getting patients back in, for example, 6 to 12 months following discharge from speech pathology services?
Okay, so if you are a radiation patient, which the vast majority of our head and neck cancer patients are, I make it very clear up front, and a lot of times this is even at a pre-op visit, that as much as you're going to go through and complete your treatment, and in 5 years your doctor's going to say, hey, bye, you're cured, I never actually will say goodbye or discharge you. So you are on a chronic 6-month surveillance should everything be stable. And if it's not stable, let's say, okay, we're at a 6-month surveillance, and look, we record everything, it's all direct visualization, so we can say, hey, this was 6 months ago, look what's happening today. And that can be very powerful for the patients to understand, especially when they are not noticing any difference in their swallow or their breathing. They feel like their voice is stable. Look at what it looked like before and look at today. And I think setting up that expectation up front, that as much as you might not appreciate this, we're going to look at you every 6 months forever and ever and ever. The joke is until I die and they decide to change the protocol. But there's never that point of discharge. And I think that expectation up front, or standard that's set up front, really sets the tone for the fact that they're never going to be discharged.
We'll take just one more question since we're at time, and I'll turn it back over to Jenny. This question is in regards to objective measurement of lymphedema. So Natalie wanted to know what objective measures you are utilizing with MBS or CT. I would also add fees in there. In general, what objective measures are you using to assess lymphedema?
So there are a few you can do. External lymphedema, obviously, when we can see it outside, the puffiness, the jowls, you can take measurements, just a standard measuring tape that you'd use for, fabric measuring, things like that. But we most commonly are doing endoscopic fees. patients are having FEES exams when we talk about that surveillance. So we're doing FEES because of the functional impact, latent and changes that can happen to the swallow function post-treatment. We're looking at them again 3 weeks post-completion, 6 weeks later, then 4 months later, then they switch to the every 6 months. If everything's okay, and if we're intervening, that certainly changes their surveillance and exam protocol, but we're looking at them endoscopically, a minimum for functional purposes with the FEES every 6 months. If there are other concerns, sometimes if I'm suspecting something going on that I'm not able to adequately assess with the FEES, then we'll schedule them for an MBS in addition to whatever it is we're looking at, or ask the physician to send a referral for a CT, and this is why. And the good thing is the physicians I work with, if I ask for something, they just handle it, take care of it, and make sure that, you know, I have all the information I need to accomplish what I need to.
Wonderful. Well, thank you so much, Katrina, for answering those questions. And with that, I'm going to turn it back over to Jenny for closing remarks.
Thank you, Brooke. And thank you so much, Katrina. And thank you to the audience for those wonderful questions. We would like to encourage you to visit our websites, which are up on the screen, for more information on future events, for resources, and follow us on social media. You'll find us at EMST150. And you can find a lot of great information at HNC4SLPs on Instagram. With that said, if you selected to receive ASHA credit for this course and you provided your ASHA member number during registration, there is nothing else for you to do but go and digest all that information. And Aspire Products will submit your CU information to ASHA. If you did not submit your member number when you registered, please email your first and last name, your ASHA member number, and an email that's associated to training@emst150.com. You will see that email right at the bottom. Again, so your first and last name, your ASHA member number, and an email associated. And we will confirm attendance and submit your information to ASHA. Thank you so much, everybody. Have a good night.